Hi, everybody. Back again for one of your last 3 lectures. We're coming up on the end of the semester quickly. This lecture is an introduction to fetal echocardiography. Pay attention, though, this actually comes out of Volume 1 in Hagen Onsert and not Volume 2, so this is actually Chapter 35. So we're going to review some terminology today. We'll spend a little time talking about the embryology of the heart. Embryology in cardiac development is very important because cardiac defects are kind of like those skeletal dysplasias in that everything that occurs in terms of congenital defects with the heart happens very, very, very early in the pregnancy due to an embryologic misstep. So understanding the basic embryology is very important. We'll talk about some techniques in fetal echo and some of the views that we utilize, as well as things that we Doppler. And then again, your favorite fetal circulation is also reviewed. So some terminology that you want to familiarize yourself with. These are probably mostly terms that you've heard before in terms of your anatomy and physiology courses. So hopefully they're not totally foreign. If you think about the electrical pathways of the heart, you have the sinoatrial node and the atrioventricular node that help pass the electrical impulses throughout the cardiac tissue, so the heart can maintain, hopefully anyways, a normal rate in rhythm. The bulbous cordis is kind of one of the very, very early structures of the heart in terms of the embryologic development. We have our ductus arteriosus, which we know is one of 3 shunts that exist. The ductus arteriosus is a shunt between the aorta and the pulmonary artery to kind of bypass the lungs. The foramen ovale is the shunt that exists between the right and left atria to help kind of push the blood that comes in the right atrium of the heart directly over into the left side of the heart to avoid the right heart and again bypass the lungs. And then we have the septum primum, the septum secundum. These are different parts of the inner atrial septum that divides the left and right atria, where we can see some congenital defects form if that septum doesn't close properly. So the blood vessels actually start forming in the embryo toward the 3rd week gestation. So before a female likely knows she's pregnant, blood vessels are already forming and actually starting to get ready to begin circulating blood around the 5th week of gestation. So what happens is there are 2 what we call endocardial tubes, literally 2 tubes. They fuse together during the 4th week, and then they undergo this really intense bending and folding process. And this occurs in a very short amount of time. Basically, in 1 week, we go from having these 2 endocardial tubes to them being fused together, bending on themselves, and then by the end of the 5th week, the heart starts beating and has a relatively normal, close to normal adult configuration. So it's a very, very quick process. And because it does happen so quickly and it is so intricate, one small misstep is what leads to the myriad of congenital heart defects that we see. So starting in the top left corner with figure A, this is out of your textbook. Those are the 2 endocardial tubes that we have. And like I said, in the 4th week, they kind of fuse together and then start kind of twisting and bending on themselves to work towards the 4-chamber, normal 4-chamber appearance that we see in the heart. The right and left atria, we don't just have a single interatrial septum that forms in one fell swoop. It actually forms in 3 different parts. So the right and left atria are actually partitioned first from what's called the septum primum. This is the part of the interatrial septum that is up towards, or I'm sorry, down towards the crux of the heart, towards the middle portion. Then you have the septum secundum, which is kind of the middle portion of the interatrial septum where the foramen ovale exists. It's the most common place that we see atrial septal defects. And then you have the septum ostium that is kind of up towards the top part of the heart where the vessels kind of start dumping in. The endocardial cushions, this is the area of the kind of the crux of the heart. So if you think about the middle of the heart, kind of in the center of the heart where it all kind of comes together. It's very, very middle of the heart. It's the level of the atrioventricular valve. So if you think about a heart where you have your mitral and tricuspid valves, kind of in the very center between the ventricles is the endocardial cushion area. So endocardial cushion defects relate to that area at the crux of the heart. The aortic and pulmonary arteries, what we call the great vessels, they form from an aorticopulmonary septum that divides and allows for the development of these two great vessels. And again, it's a very, very delicate process that can lead to abnormalities such as both great vessels arising from the same outflow tract, like a double outlet right ventricle, where the aorta and the pulmonary artery actually arise out of the right side of the heart instead of one from each. The aorta and pulmonary arteries, the base of those vessels cross each other at roughly 90 degrees. So that relationship is really, really important sonographically, because when you're imaging the great vessels, looking at a fetal heart, your LVOT, your left ventricular outflow tract view, and your RVOT, your right ventricular outflow tract view, you should never see both of those vessels lengthened out in the same image. Because they cross each other at 90 degrees, you're typically going to see one long and one short, kind of in a short axis because of their relationship with each other. If we see them both in a long axis in the same image, that's not a good sign. So that's important to remember. And then you can see kind of the formation of the SA node and the AV node and kind of where they come from. I told you that this diagram would haunt you for all of your days. It's back again. Be sure that you take the time to review this again. Make sure you're familiar with fetal circulation, the location of the 3 shunts, and you have a pretty solid understanding of fetal circulation. I'm not going to beat it again because we've talked about it so much already, but be sure you review this diagram and that you feel comfortable with it. And if not, please reach out to me so that we can work through it. In terms of heart rate assessment, this is a little bit of a review because we've talked about it some already, but a normal heart rate is 120 to 160 beats per minute outside of the first trimester. When the heart begins beating in the first trimester, right around week 5, it's a little bit slow, so it's around 90 beats per minute. So that's important to remember, because if you're scanning a very, very early first trimester and you note a heart rate of 90 or 95, and they're really close to that 5-week gestational age mark, that's likely totally normal. And then in the first trimester, you can see the heart rate get up to as high as 170 beats per minute. But 120 to 160 is what we look at kind of outside of that first trimester. Anything below 60 beats per minute, we consider bradycardia. It's a very slow heartbeat. Anything greater than 200 beats per minute, we consider tachycardia. And those are always important things to document. When you're measuring heart tones, which you should do every single time you scan a patient, whether it's a full study or a limited study or whatever, you always need to confirm, not just confirm fetal heart tones, but also measure the heart rate. That's a very important part of your documentation for OB exams. Certain connective tissue disorders like SLE, which is lupus, a form of lupus. Some connective tissue disorders are more closely related with abnormal heart rhythms, such as a heart block. Heart blocks can be difficult, or a lot of rhythm abnormalities can be difficult to assess sonographically, like in a routine anatomy scan. But if we see something that looks abnormal, you want to try to obtain like a cine clip to document that it looks like the heart slows down and then speeds back up, or it kind of has a pause in it or something like that. And they can refer them out for a fetal echo where that can be observed a little more closely. It's not abnormal for a fetus to kind of have just a really quick kind of a quick pause or just a single abnormal beat. I mean, I get you get that feeling where you feel like your heart skips a beat every now and then. That happens to me all the time. It's not totally abnormal, but it is important to document because it could be a sign of something like a connective tissue disorder. Pericardial effusions are also commonly seen with some of the connective tissue disorders. Okay, so like we said, 120 to 160 beats per minute is the normal range for heart rate in the kind of the second part of the pregnancy, second trimester into the third. The important thing to note, though, is in the second trimester, if you see what we call transient bradycardia, meaning the heart rate kind of dips down low, like to 60 or even lower, and it comes right back up, in the second trimester, that's totally normal. That's totally fine. In the third trimester, it is not. When we see transient bradycardia in the third trimester, it's a strong sign that the fetus is in distress. It's what you'll hear obstetricians refer to as we need to look for decels or decelerations. And that is the reason why when mothers are laboring, they keep that band on their belly to monitor the fetal heart rate, because the second the heart rate dips below a number they deem safe, especially if it stays there for a little bit longer than the docs like, then that's an emergency section, get the baby out. So in the third trimester, the transient bradycardia is not normal and definitely needs to be documented. So why are we going to spend 3 lectures talking about fetal echo? It's not just because I love echocardiography. The reason we spend so much time with it is because it is so much more common than people realize. So 1% in all live births, which doesn't sound like a whole lot, but when you are talking about worldwide, there being, I can't remember the exact number that I pulled recently, it's over 1 million. Live births that happen worldwide every day. And so 1% of 1 million, that's a lot of congenital heart defects. And congenital heart defects occur in roughly 5% of all pregnancies. And if there's a family history, a positive family history of a congenital heart defect, then the incidence for a sibling to be affected is 2 to 4%. So there's an increased risk there. If mom has a congenital heart defect, then the developing fetus has a 10 to 12% increased risk of also having a congenital heart defect. So they're actually a lot more common than people realize. Now, they're not all the incredibly complex, rare defects that we'll talk about in the lectures that follow this one. Some of them are very simple, very tiny, small ventricular septal defects that heal on their own over time, but that's still considered a congenital heart defect and gets counted in that 1% of all live birth tally. So some other risk factors, trisomies. Most of the trisomies have associated or an increased risk for having congenital heart defects. We always, talk about trisomy 21 because it is relatively common. Endocardial cushion defects and ventricular septal defects are very common in trisomy 21 cases. More complex defects are typically seen with the other trisomies like 13 and 18. IUGR is an increased risk for congenital abnormalities. Typically, if you document high drops or an abnormal fluid collection like a pericardial effusion, do you want to do a pretty thorough evaluation as you can? If not, refer them out for a fetal echo for a closer look. Maternal risk factors, of course, a previous occurrence of a congenital heart defect, a CHD, in siblings, parents, first-degree family relatives. Diabetes is another one, connective tissue disorders like lupus, drug use. So, and we're not just talking about, cocaine, like I always bring up. This is like prescription drug use, maybe. So lithium, patients that are bipolar, sometimes are prescribed lithium to help stabilize their mood. And that has an increased risk. Taking that medication has an increased risk of congenital heart defect formation, and then alcohol ingestion as well. Let's see, any genetic syndromes of a sibling. So if there is a previous child, say with trisomy 21, they may be at an increased risk for another baby being born with a CHD, or if there's a sibling with a congenital heart defect, again, it's an increased risk. It is important to note that the most common congenital heart defect that's out there is the VSD, the ventricular septal defect. When it's isolated and they're small, they usually don't even do anything about them. They'll monitor it closely for the first year of life. And a lot of the times as the heart muscle grows, it'll kind of patch that little hole on its own. The larger defects are typically going to be associated with other cardiac and other anomalies outside of the cardiovascular system. Sometimes they require surgical intervention to repair. All right. So in terms of the technique for imaging the fetal heart, it's not an easy thing to do. There's a reason fetal echo has its own credential. It's a lot of work, and it's very complex work imaging the fetal heart. And there's a lot of barriers that can kind of hinder your ability to image the fetal heart well. So maternal body habitus is going to first and foremost be your biggest issue. Unfortunately, some patients have a more difficult body habitus than others, and it can make imaging the fetal heart difficult. Gestational age will determine what your transmit frequency needs to be. If you're later in pregnancy imaging the fetal heart, you're probably going to have to use a lower frequency because you're going to need the beam to penetrate a little bit more. As bone is more ossified, you're going to have more shadowing. The exam is going to be a little bit more difficult. Earlier in the pregnancy, you can likely use a higher frequency to get better detail. The transverse lie, if a fetus is in a transverse lie, it's almost always that their heart is directly underneath the mom's belly button. And as you know, that can create a pretty dense shadow because you don't have direct contact with the skin when you're imaging in the belly button. So what you can do is actually take an endovaginal transducer, fill the belly button full of gel, and try to image the fetal heart through mom's belly button. I know that sounds crazy, but it can work, and you can get that really high frequency transducer to try to penetrate some of that and kind of close that air barrier from the belly button. And sometimes it works, sometimes it doesn't, but it's definitely something to try. In the cardiac world, we rely heavily on cine clips and short 2 to 3 second video clips. The heart is an organ that is moving all the time. It's constantly beating, or so we hope. And for the fetal cardiologist, the pediatric cardiologist, to get accurate information in terms of cardiac function and how the heart looks overall, they have to see it moving in real time. So using cine clips, we don't really see the disc or the video recording anymore now that everything is digital. You're going to do a lot of zooming if you're looking at very specific parts of the heart, the valves, the ventricular septum, the interatrial septum. M mode is used a lot in both fetal and pediatric echo. We use it some in adults, not as much as we probably should, but it gives a lot of really helpful information. So for those of you that do decide to come onto the cardiac track, you're going to learn a lot about M mode because we use it quite a bit. You will always use duplex scanning, so you're going to be using a lot of color Doppler, mostly to assess blood flow across the valves, and also looking at the how intact like the interventricular septum is. Color Doppler can really help us look at ventricular septal defects. And then when fetal echoes are performed, they also use spectral Doppler and sometimes continuous wave Doppler to measure flow velocity across valves. There is such thing as congenital aortic stenosis and congenital mitral stenosis that can cause the velocities of blood across those valves to be elevated. So kind of going a little bit further into it with M mode, like I said, we use it quite a bit. It's going to evaluate cardiac motion. It's a time versus depth display. Remember, we're not measuring velocity with M mode. It's time versus depth. So we can look at movement patterns of valve leaflets, of the myocardium. So there's a lot of really helpful tools that come along with using M-mode, we can get a lot of information. Pulse Doppler is probably used more than continuous wave Doppler in terms of fetal echo. Pediatric echo, we use a combination of both, but looking at things like regurgitant jet, so if we're worried about a leaky valve, it's very helpful with that to determine how bad it's leaking, and then also, like I mentioned, with the stenotic valves. Color Doppler, I mentioned, helpful in assessing for ventricular septal defects. 3D is used some with fetal echo when we're worried about abnormal cardiac structures, and if we can get really good three-dimensional images, when we get that three-dimensional model that's built from the information that's obtained, it can be really helpful. It's not currently better than two-dimensional imaging for structural analysis, but it's getting there as the technology improves. So some of the landmarks that you want to make note of when you're looking at the fetal heart, and this is regardless of whether or not you're doing a fetal echo or if you're just doing a routine cardiac examination as part of an anatomy scan. The very first thing that you have to do is determine fetal position, fetal line presentation. Where's the head in relation to the cervix? What's the fetal left? What's the fetal right? You have to start there. You're going to be kind of fighting a losing battle trying to determine if the heart's on the right side of the chest or if everything is where it should be if you don't understand the fetal line presentation. So that's first and foremost. Once you do that, then you can go and start evaluating the thoracic cavity and determine if the heart is in the proper place in the thoracic cavity. From there, you always want to take a quick look at where the stomach is. So if the heart is in the normal location pointed towards the left side of the fetus, you should be able to scan just slightly inferior and see the stomach directly below the diaphragm. If you don't, give it a few minutes and see if the stomach may be just emptied and it's going to fill back up. Or if you kind of sweep down and you notice that the stomach is kind of closer on the other side, then it's time to start thinking, okay, if I know and I'm confident that the heart is in the correct side of the chest, but the stomach appears to be on the right, we want to make sure that we document that. Looking at the position of the apex of the heart should be pointed 45 degrees plus or minus 20 degrees to the left. If it's not, we need to document aorta and IVC. We want to look at the placenta as always. And we want to do at least at the minimum a BPD measurement and a femur length measurement for gestational age correlation. If we're worried about cardiac size or thoracic cavity size, there are established norms that relate and correlate those measurements to gestational age, and looking at the BPD and the femur length can help us determine if all of our measurements are kind of falling in line with each other and maybe our dates are just off, or if we only have one or two measurements that are not correlating well, then we've got a bigger problem we need to evaluate. So this is just showing some of the basic fetal heart anatomy. So you have your line drawing over here and then your sonographic image here. So you've got your spine. Right down here, you've got your three kind of vertebral ossification centers with a spinal cord and canal in the middle. Directly on the kind of up and just slightly to the left, you should see a cross-section view of the aorta. Here, that's what we're seeing. There's a cross-section view of the aorta. Kind of directly following that, you have the left atrium here, the right atrium here, right ventricle and left ventricle. And as we go through, I'll show you a trick that can help you differentiate the right ventricle from the left ventricle to kind of give you a kind of a cheat sheet because it can be difficult to differentiate left and right. But you have to remember to look at an image like this in its entirety. Where's the spine? Where's the aorta? And then that can kind of help you determine left or right. If I know the aorta is here, I also know that the left atrium is the chamber of the heart that lies closest to the spine. Then you can kind of talk yourself through determining whether or not what you're seeing is normal or abnormal. Okay, so now we're going to go into kind of what the echocardiographic evaluation should look like. Like I said, this has its own slide. It's very important. The very first thing you need to do is assess fetal line presentation. What is the fetal position? What is fetal left? What is fetal right? And you want to make sure that you're well oriented with that before you start going into your really in-depth evaluation of the heart, because again, it's going to be very hard to document normal or abnormal if you're not first confident in your evaluation of the fetal position. So standard for any routine anatomy scan is to at least get a 4-chamber view of the heart. There's actually a lot of information that we can obtain from a standard 4-chamber view of a fetal heart. It's the easiest view to demonstrate cardiac anatomy. It's not as challenging as some of the outflow tract views and other vessel views that are out there. But we can look at the size of the atria and the ventricles compared to each other. So the left side of the heart and the right side of the heart should be relatively the same size. You will notice in most cases that the right ventricle and the right atria are slightly larger than the left. The reason for that is volume, a little bit of volume overload. Because everything is entering in that right atria on the right side of the heart and it's trying to shunt over to the left, it puts a little bit of pressure on the right side of the heart, which is normal. It's totally normal, but you'll notice that the right side of the heart is slightly larger than the left. From this 4-chamber view, you should also note the foramen ovale opening into the left atrium. You'll notice that little flap, and it should be opening into the left side of the heart. And then the moderator band, this is your cheat sheet. And we'll look at some images that demonstrate the moderator band clearly. It's basically like a part of the muscular part of the endocardium, the most inner layer of the heart. And near the apex of the heart in the right ventricle, you have this moderator band. It's one of the first things I look for in a 4-chamber view because it helps me reassure that I have my left and my right correct, and that the what I'm seeing and what I think that I'm believing as, okay, this is a normal position of the heart, left and right are what I expect them to be. And I feel confident with that. Looking for the moderator band can kind of confirm and just kind of reiterate your confidence on determining the left and right. And like I said, we'll look at a couple of images of what the moderator band looks like here in a minute. So continuing on looking at our 4-chamber view, we also can look at the position of our atrioventricular valves, our AV valves. So we have our tricuspid in the right and the mitral valve on the left. When you're looking at a 4-chamber view, you will notice that the tricuspid valve and the mitral valve are almost at the exact same level. Typically, the tricuspid valve is going to be slightly inferior to the mitral valve. And when I say slightly, I'm meaning slightly, usually just a few millimeters difference. To the naked eye, they look relatively even in terms of their location. You should be able to note the pulmonary veins dumping into the left atrium. In the 4-chamber view, the right lower pulmonary vein is the only one that's not visualized. Just due to how the beam is coming through, it makes that one a little bit more difficult to image. You can kind of sweep through and see the IVC and the SVC entering into the right atrium. If you need to measure the diameter of the right ventricle and the left ventricle, which when you're doing a full fetal echo, they typically do, but when you're looking at the heart in a routine anatomy scan and assuming the RV and the LV look relatively the same in size, you don't normally measure them, but they should be roughly 6 millimeters across. And this is kind of an inner edge to inner edge measurement of the cavity. And I'll show you an example here in just a minute. Anytime we note abnormalities in the atrioventricular valves, whether it be their position, they look like they're thick and they're not opening well, or we have a significant difference in the size of the atria, Doppler needs to be performed to look and see, okay, do we have a valve that is stenotic? Do we have a valve that's leaking? What's going on that's leading to the findings that we see? Acquiring a 4-chamber view, like I mentioned, it's the easier of the fetal cardiac views to get. It's basically a transverse section through the fetal thorax. So you want to get the thoracic cavity in a transverse view. It should correspond to the 4-chamber apical view in the adult. So you should see both ventricles and both atria in the same plane. The left atrium is the one that's closest to the spine. Remember that. It's going to help you in terms of, again, feeling comfortable discerning left and right, and then making the determination of whether or not the appearance of the heart is normal or abnormal. So left atrium closest to the spine, the right ventricle is nearest to the fetal anterior thoracic wall. So the anterior chest wall is right ventricle is closest to that. The left atrium is the chamber of the heart that's nearest to the spine. So this is an example, kind of a line drawing showing this transverse view through the thoracic cavity with our 4-chamber heart here. So this is our spine back here, and this is our anterior chest wall. So because of what we just talked about, we know that this should be the right ventricle of the heart. This should be the left atrium, because closest to the spine, closer to the anterior chest wall. In terms of the axis of the heart, roughly 45 degrees off the midline. This should say plus or minus. 45 degrees plus or minus 20 degrees. 45 degrees to the left, plus or minus 20 degrees. If it's not a perfect 45 degrees, that's okay. But when we start seeing it, standing straight up or pushed really far over at almost a 90-degree angle over here, then we're concerned that there's some other process going on in the chest that's pushing the heart one way or the other. Is that a congenital diaphragmatic hernia and it's bowel or part of the liver that's pushing the heart over? Or is it a CCAM or a CPAM, a lung mass that's pushing the heart one way or the other? Anytime we document an abnormal cardiac axis, there's an increased risk for a cardiac malformation to occur. This is just an example of a fetal lie, kind of line drawing, looking at feeling comfortable with determining, okay, if the fetus is cephalic and there's a posterior spine, I know that this is the direction the heart should be laying. So go back to your fetal line presentation workshop and looking at the images to determine fetal lie and make sure that you feel comfortable with that. This is a perfect example of if you're not comfortable with that and you're like, oh, okay, well, the last patient that I scanned, they had a posterior spine, but the heart was pointing the other way, so therefore this has to be abnormal. Not necessarily. The last one was a cephalic presentation. This is a breech presentation. So if you think about flipping the fetus around in utero, it's totally normal for the heart to be pointed this direction due to that fetal presentation. At the very, very, very least, the basic fetal cardiac exam done as part of the anatomy scan is to obtain a 4-chamber view, determine the axis of the heart, its location in the thoracic cavity, that there's fusion present, that the size of the heart looks relatively normal. It should occupy roughly 1/3 of the thoracic cavity. This is just the basic minimum. As part of a routine anatomy scan, you should definitely be doing more, like looking at the outflow tract, origins and things like that, but this is the very basic. Part of that really basic exam is to look at the size of the left and right ventricles. Are they relatively the same size? Remember, the right side of the heart will be slightly larger than the left, and that's okay as long as it's not a stark, drastic difference. You should use color Doppler to assess the interventricular septum and make sure we don't see any holes shown by the color Doppler. And then lastly, to kind of help you confirm left and right, you can look for the moderator band in that right ventricle. So this is an image from UAMS. So here's our spine back here. So we're seeing the spine. This is the left side of the spine. So this is a cross-section view of the aorta. We know that in normals, which I'm going to give you normals, I'm not going to give you a bunch of abnormals because we'll talk about it and know what you should look for sonographically, but it's very hard to determine an abnormality based on a single or even a couple still images. It's really not beneficial unless you're scanning in real time. So think of normal for the time being. So because we know that the left atrium is situated closest to the spine, aorta, left atrium, here's our right ventricle closest to the anterior chest wall. It's kind of hard to see, but this little guy right here, this is the moderator band going across the apex of the right ventricle. You don't see that over here on the left side. So if you're like, okay, I know the spine is here. I think this is the left atrium. Okay, yeah, I see the moderator band there, so I'm good in terms of my left and right. It's situated in the heart, or sorry, in the chest in a normal fashion. Both ventricles appear to be relatively normal in size, as well as the atria. Our valves, tricuspid valve and mitral valves, look like they're at relatively the same level. The tricuspid is slightly inferior. That's okay. And you can actually see part of the foramen ovale opening into the left side of the heart right here. So if you can get a solid 4-chamber and you can discern those basic things right there, you've already ruled out a significant portion of congenital heart defects. So that's good. But we can take it a step further, which we'll talk about here in just a second, and be able to effectively rule out virtually 95% of all congenital heart defects if we just take the time to get familiar obtaining just a few more images. This is the measurement that I was talking about. If you need to measure kind of the diameter of the ventricle, this is what you're doing. Roughly 6 millimeters is what's considered normal. This looks like it's the right side of the heart over here, so it's slightly larger than the left, which is okay. And they're basically just taking their calipers straight across just below the level of the valve. So here's the mitral valve. Here's the tricuspid valve. So they're just underneath that, kind of at the widest portion of the ventricle. And because there's such a slight difference in them, it's likely totally normal. I would argue that this caliper is probably a little bit too far. I think it needs to be moved in just a little bit there. So again, following up with some more information with this basic fetal cardiac exam, we looked at the position of the AV valves, and we also just want to make sure that they're moving freely. If they are really echogenic and they don't look like they're opening and closing, well, you don't see what looks like hands clapping. That's how a lot of my patients have described when they see their heart valves moving, hands clapping. If they don't look like they're moving freely, if they look very stiff, that's something that we need to document. Out of fear for, not fear, but out of concern for congenital stenosis of a valve. Atria, again, roughly the same size. The foramen ovale should be opening into the left side of the heart. This is the septum primum down here. We want to make sure that it's present. When it's not, this is where we start getting concerned about endocardial cushion defects. So this would be where endocardial cushion defects occur. This is the crux of the heart right here. And we get a little bit worried about more complex cardiac defects when we don't see the lower portion of the septum present here. This area would be the secundum, and then up here you have the ostium. It's way up here. All right, so looking at this right here, so we have the lower end of the septum present here, and then we have this foramen ovale opening into the left side of the heart. Why do I know it's the left side of the heart? Because again, I'm assuming normal. This is the cross-section view of the aorta. The spine is right back here. Left atrium closest to the spine, so therefore we should see the foramen ovale opening into the left side of the heart. This is a really interesting image. So when you think about imaging a fetal heart on a 20-week fetus, think about a quarter. That is roughly the size of a fetal heart at 20 weeks. It's the size of a quarter. And what's really interesting is that very early in the pregnancy, by like 6 weeks gestation, the fetal heart has a complete adult configuration. It's just like your heart or my heart, it's just much smaller. So all of the, everything is in place very, very early in the pregnancy, and it just grows and gets larger as the pregnancy progresses. But I've always thought that this was a really interesting image and an interesting perspective about just how small a 20-week fetal heart is. So here are some more images. We've got our basic 4-chamber right here. So again, spine, aorta, left atrium, left ventricle, right atria. So you want to really start familiarizing yourself with the basics, like we've talked about. So the ventricles look relatively the same size. Atria look relatively the same size. If we were scanning this in real time, we would see that these AV valves are moving freely. It looks like we have a foramen ovale that's opening to the left side of the heart. If we look at the axis, if we put a line right down the middle of the thoracic cavity, the heart is roughly 45 degrees off the midline. So those are all of the things that you want to be kind of going through in your head as kind of like your checklist when you're doing a basic fetal cardiac evaluation. We'll talk a little bit more about outflow tracts here in just a second, but this is a left ventricular outflow tract. It's likened to a ballerina slipper. So you think about this as a foot and an ankle. That's kind of what the left ventricular outflow tract looks like. So again, you've got your spine, aorta, left atrium, left ventricle, and then what you're seeing right here is the aorta. The aortic valve is kind of right in here. So we have the blood leaving the left ventricle and going across the aortic valve, where it's going to make its way up through the arch, down through the descending part of the aorta and into systemic circulation. We're going to go into these views in a little bit more depth. I know it's kind of hard to see in this image because they're small, but this gives you an idea of kind of how we progress through the views of the heart. So we start at what we call the base of the heart. So we're way up here, kind of taking a cross-section view of the great vessels. We move down just a little bit into this area right through here, where we're seeing the main pulmonary artery coming out of the right side of the heart. And you're seeing this vessel lengthened out, which means you're seeing a cross-section view of the aorta. The pulmonary artery looks like, in this view, it should appear as if it's wrapping around the aorta. And again, these vessels cross each other at 90 degrees. So if you're seeing them both in a long view in the same image, something is wrong. You should not see them both lengthened out in the same view due to that 90-degree relationship that they have with each other. If you're seeing one lengthened out, you should see the cross-section view of the other. So you have your main pulmonary artery and then your left and right branches of the pulmonary artery. The best way to differentiate between the pulmonary artery and the aorta is that the main pulmonary artery branches right off the base. The aorta does not. You don't see branches in the aorta until you get up into the arch. We move down a little bit and we're kind of in this left ventricular outflow tract view. We sweep through just a little bit more and we come into our four-chamber heart. And then as we sweep through just a little bit further, now we see the stomach. So you have heart pointing to the left, and as you angle slightly inferior, now you see the stomach just below the diaphragm where it should be. So just a couple more examples of the foramen ovale opening into the left side of the heart here. This one's much more clear. Spine back here. You don't really see a good view of the cross-section of the aorta here, but we see the foramen ovale opening into the left atrium. So if you really want to take your basic fetal echo up a notch, add imaging the outflow tracts to your four-chamber evaluation. When I talk about outflow tracts, we're basically talking about the origin of the aorta in the LVOT, the left ventricular outflow tract, and the origin of the pulmonary artery in the RVOT, the right ventricular outflow tract. This allows us to see the relationship of the great vessels. Do we see that they're crossing each other at 90 degrees? Are the correct vessels originating out of the correct side of the heart? If we can prove that our four-chamber view is normal and our outflow tracts are normal, we are eliminating virtually 95% of all congenital heart defects. That is huge. Outflow tracts are not easy to image. It does take some practice to get more comfortable with them, but they add significant value to a routine anatomy scan when looking at the fetal heart. So like I said, this is kind of an extended basic cardiac examination, and really the outflow tracts should be included in a basic examination with what we know about them. The outflow tracts are imaged basically by tilting the probe and the beam up towards the fetal head. The great vessels kind of come out of what we call the base of the heart, so closer to the atria, the atrial area. So if you angle your beam up towards the fetal head, this is how we get the views that show the outflow tracts. The diameter of the great vessels should be relatively equal in size. The right or the pulmonary artery may be slightly larger than the aorta, and that's okay. And again, they should cross each other at roughly 90 degrees as they emerge from their respective ventricles. The long axis view, this is kind of the view that we use to obtain our left ventricular outflow tract. You can see the interventricular septum well here. The interventricular septum, in terms of the measurements on it, we don't typically measure it in the routine exam unless it looks abnormal. In the second trimester, it's 2 to 2.5 millimeters in thickness. Third trimester, it can be as much as 4 millimeters, but when it's greater than 5, we start considering some pathology in terms of septal hypertrophy, it's really thick, or concentric ventricular hypertrophy if the entire left ventricular walls, if all of the walls look very thick. There are some inherited conditions that can cause that to happen. That's really important to document during the fetal period, because there are certain medications that they can give, like beta blockers after birth, that can relax that thickened muscle a little bit and actually correct it somewhat in a fetus and in a neonate, to kind of help control that situation a little bit better. We should see continuity of the anterior aortic root wall and the right side of the septum. So when you're looking at, and we'll look at an image of, and I'll point this out, when you're looking at the left ventricular outflow tract, you should see the interventricular septum from the apex all the way up through, and it should continue nice and smooth up through the origin of the aorta. It should be nice, clean, smooth. You shouldn't see any breaks or any holes. If you do, you need to first make sure that it's not just dropout happening. So you want to use your color Doppler and make sure that you're not seeing a communication between the left and right side of the heart there. From here, you would want to angle the transducer slightly anterior and medial when you see the aortic root, and that should give rise to the RVOT and the pulmonary artery. And again, from here, you're seeing the aortic root kind of lengthened out. You should see the base of the pulmonary artery in cross section from here, because again, that 90-degree relationship. Usually the pulmonary artery is just slightly larger at its origin than the aorta, but not significantly. When we move into our short axis view, we're turning our transducer 90 degrees counterclockwise, usually from that long axis view. We have what we call a high short axis. This is kind of, again, at that base area of the heart where we're looking at the origin of the pulmonary artery in the aorta. Again, to differentiate between the two, your pulmonary artery is going to almost immediately bifurcate, whereas the aorta will not. At 20 weeks gestation, if you measure the diameter of the great vessels, roughly 4 millimeters is what you're looking for. If there's a stark difference between the measurement of the two, you need to document it. Let's see if we need to do Doppler evaluation, spectral Doppler evaluation. We can drop a cursor into the pulmonary artery, and it should be roughly 60 to 80 centimeters per second. As we get closer to the ductus arteriosus, that shunt between the pulmonary artery and the aorta, the velocity increases drastically, and you're going to see roughly 150 centimeters per second there. You don't have to stress about those numbers. I'm not going to test you over those specific numbers in terms of the velocities. That just gives you an idea of how fast the blood is moving through there. As if I haven't said it enough already, the outflow tracts cross each other at 90 degrees. So this is the origin of the pulmonary artery out of the right side of the heart. So think about it like this. The pulmonary artery is going to come out and go this way. If we had this image down over here to be the left side of the heart, the aorta is going to come out and go this way. Let's see if I can draw it. So if our pulmonary artery continued down here, say we had the left side of the heart over here, the aorta is going to come out and it should cross it at roughly 90 degrees. So again, if I'm seeing this vessel in a long view, I should only see a cross-section view of this one. Likewise, if I see this one right here in a long axis view, I should only see this one in a cross-section. So that's that relationship, and that relationship is very important to document and to understand, simply because if we start seeing something, let me see if I can erase. Oh, there we go. If we start seeing something that looks like this, we note our pulmonary artery coming out of the right side of the heart, but then we also notice this right next to it. It's a major red flag. This would be what we would call a double outlet right ventricle. Both of the great vessels are originating from the right ventricular outflow tract, and that's not good. Because we don't then have any communication from the left side of the heart to take blood from the left ventricle out into systemic circulation. So that's why understanding that relationship is so important. And hopefully my lovely artistic skills kind of gave you a better understanding of what I'm talking about when I say that the outflow tracts cross each other at 90 degrees. Like I said, to help you understand the difference in the aorta and the pulmonary artery, this is the main, let me get my pointer back. This is the main pulmonary artery right here, and it's going to almost immediately bifurcate into the left and the right pulmonary arteries. This is a better view right here, and I like it next to this line drawing because it helps kind of provide some more information. So you have your right atrium, you have your tricuspid valve, the right ventricle, and then you have your, this is the pulmonic valve right here. This is your main pulmonary artery immediately below the valve, and now you have your differentiation of your left pulmonary artery and your right. This right here is a cross-section view of the aorta. So remember that 90-degree relationship. It looks like the pulmonary artery is kind of wrapping around the base of the aorta. That's what we want to see. That's what we should see in a normal situation. All right, so continuing on, we should also obtain images of both the ductal and aortic arches. They're typically kind of an oblique view that has to be used to image these, and you're going to need to get a really good it's kind of a makeshift sagittal slash coronal view to see these. The way that we can tell the difference between the two, the aortic arch is what we call candy cane shaped. It's much more, the arch itself is much more narrow, and it has branches. So you can turn color Doppler on and look for the branches if you're having a hard time differentiating between the two. The ductal arch is more of a hockey stick shape, so it's a wider arch. It's not as narrow as the aortic arch. It has no branches, and when you turn your color Doppler on, you can actually see a communication between the pulmonary artery and the aorta, which is our ductus arteriosus, hence the name ductal arch. You can angle your transducer slightly inferior from the aortic arch view to obtain an image of the ductal arch there. So this is a beautiful image of an aortic arch from UAMA. So we're kind of in a sagittal, somewhat oblique sagittal view. This is our candy cane shape. So that you see the arch is really narrow right here, and we can kind of follow it all the way down through the descending portion. If we were to put color Doppler on, you would see the branches light up. This is a really good differentiation between the aortic arch and the ductal arch. I know that it's kind of an old image, but it does kind of help you better understand the difference between the two. So the first thing we notice is how narrow this arch is here versus this one right here. It's a much wider arch. Here you can also see with color Doppler on the branches coming off, and then you don't see any branches coming off here. It's important to note that the aortic arch and the ductal arch, they are separate, but there aren't two, they're not two separate vessels, if that makes sense. When we're talking about the ductal arch, what we're wanting to basically say is this is still descending aorta down through here. But instead of looking at the origin of the ascending part of the aorta, like we are over here, we're basically kind of picking up this arch at the level of the ductus arteriosus. So it's still the same vessel down through here. We're just angling different to see the origin, whether it be coming out of the left side of the heart or more so out of the right side of the heart at the ductus arteriosus, if that makes sense. If you're having a hard time understanding that, reach out to me and let me know, and we'll make sure that you understand it. So the biggest takeaways that you want to remember, like I said, if I haven't said it enough, the outflow tracts cross each other at about 90 degrees. The anterior aortic root wall should be continuous with the interventricular septum. So it should be nice and smooth when you move up from the interventricular septum up to the origin of the aorta. The pulmonary artery bifurcates and the aorta does not. The aorta has branches, but the vessel itself does not bifurcate until you get way down low into the to the iliacs. The aortic and pulmonary valves should move freely, as well as the mitral and tricuspid valves. Both great vessels should be of similar size, but the pulmonary artery tends to be slightly larger, and that's okay. Same with looking at the right-sided chambers versus the left-sided chambers. Should be relatively the same size, but one can be slightly larger. I'm sorry, the right side will likely be slightly larger than the left. Okay, so I know that's a lot of information. We are going to start in our next lecture talking about some of the congenital heart defects. We break it down into left-sided defects and right heart defects. The next two lectures are not near as long as this one is, but this is just to provide the basic overview into fetal echo, how the normals should appear, kind of what you're looking for, what you're evaluating, and then we will move into the pathologies related to the fetal in the next couple of lectures.